Good morning. So glad to see everybody here, settling down. This is like an amazing panel here that basically needs no introduction. To have Tim and Narda and Nicole and Alison together, I tell you, I know they're going to be talking about the future of long-term care, but honestly, I'd probably just listen to them talk about pizza. This is all good. This is really a pleasure, right, just to be up here with them, thinking through and transitioning from the last panel, right, on sort of the vision, envisioning the future, of benefits in a time of change to the future of long-term care. Thinking through that, and thank you to the last panel, I did catch part of it, so that was really nice. It's going to take strategy, right, really intentional strategy. We have the right people up here for that and in the room. But what does it take? It's going to take agility, flexibility, collaboration, tenacity, patience, probably a glass of wine or two, to get through this and to ensure that we have an inclusive and sustainable structure and ecosystem and infrastructure for people with disabilities and older adults. Keeping in mind, most importantly, right, that what we all want is access to health care, access to the supports, to live in our communities, to choose health care, to be supported by the people we choose, and for it to be respectful and inclusive and sustainable. So I think this is going to be an amazing panel to do that for you. I hope you all enjoy the rest of the day if I don't see you, and hats off to Narda and the team.
Great, thank you so much, Meryl. And I recognize that we're in between you and lunch, so we're gonna do our best to keep everything on time. Before we get started, just a quick introduction. I'm Narda Ipakchi, Vice President of Policy and Programs at the SCAN Foundation. Our mission is really focused on ensuring that all of us can age well with purpose, and that is with a particular focus on ensuring affordable and accessible long-term services and supports. I do want to provide just a quick opportunity for each of my fellow panelists to just briefly introduce themselves, even though we know they don't need any introduction. So if you wouldn't mind, Alison, if you want to go first.
Sure. Hi, everyone. I'm Alison Barkoff. I am a health law and policy professor at George Washington University. I also, as was announced yesterday, just joined as a senior fellow here at NACI, which I'm really excited about. And I have for about 30 years professionally been doing roles inside of government and in nonprofit focused on disability and aging and long-term services and supports.
Thanks. Hi, everybody. I'm Nicole Jorwic. I'm the Chief Program Officer for Caring Across Generations. I also co-chair the Disability and Aging Collaborative with John and Natalie, who I think are in the room. And have worked at both the state and federal level on access to specifically home and community-based long-term supports and services for the entirety of my career. I'm glad to be here today.
And I'm Tim Engelhardt. I'm the Executive Director of the Aging and Disability Health Policy Lab, which is a new nonprofit, nonpartisan endeavor intended to help advance good state and federal health policies that improve access and experiences for low-income older adults and people with disabilities.
Great, thank you. So just I think to start with a little bit of level setting, I think Rebecca really captured it well in her opening. We are at a unique moment in time and in history. One that comes with a lot of policy volatility that will result in material harm to a lot of the populations that the people in this room care about. But at the same time, a wake-up moment. People across the country, the media, policymakers on both sides of the aisle are sharing story after story of people going through countless hoops to get the healthcare services that they are technically eligible for. And while quality and access and affordability suffer for real people, shareholder earnings for a lot of those companies providing that care are growing. LTSS, which used to be a really niche issue, is now a regular topic of conversation. Demand is growing. People realize how limited and underfunded the coverage is and just how hard it is to access, and how much those difficulties impact not only the care recipient, but also their families, family caregivers, the direct care workforce, and their communities. So I'm really excited that we have this stellar crew to talk more about how we can move policy, both near-term fixes to Medicare and Medicaid, to things like bold ideas like a Medicare home health benefit. But what really unites all of these efforts, both the incremental and the bold and long-term, is a shared focus on readiness. That means having policies ready to go. That means having coalitions that are united and ready to act. And that means having messaging that resonates so the public is behind those policies. So I'd like to talk to each of our panelists about the work that they're doing in this vein. Tim, I'm going to start with you. As you just said, you've stepped recently into a leadership role of the new Aging and Disability Health Policy Lab at a moment when many people feel constrained and yet deeply aware that the status quo isn't working. So from where you sit, what are the real opportunities for policy change right now at the state or federal level that might not be obvious at first glance?
Well, building off of the last panel, my opportunity will be a revolution in simplifying and improving user experience with our public healthcare programs. Too often in policy land, we ignore the mechanics of how things work. That prior panel just gave articulate voice to how those mechanics affect people in other social insurance programs. Certainly the same is true in Medicare and Medicaid, where the simple process of enrolling is often a complex and demoralizing ordeal. So many people, like in the VA example you heard earlier, many people don't access those benefits at all. There's a growing body of research that just the mere administrative burdens and processes themselves are a driver of inequity. They fall disproportionately on the experience of disability. And when we think about the stakes that are involved in long-term care and healthcare, these are functionally civil rights issues. I say this in full recognition of the reality that the reconciliation bill passed last summer aggressively deploys administrative burden to ration healthcare. Of course, in my world, I'm thinking primarily of work reporting requirements and every 6-month redeterminations of eligibility for certain Medicaid beneficiaries and a 10-year moratorium on a body of rules that would have vastly simplified enrollment into Medicaid and the Medicare savings programs. Ironically and collectively, this will vastly expand the administrative state. It will mean millions of hours of red tape for older adults and people with disabilities. And of course, people will lose coverage, or the coverage they still have will become much less affordable. If there's a silver lining to it, though, I do hope it will cause us to focus much more intensively on the intake and retention processes for our public health programs. I think in the really short term, we have state Medicaid agencies who are scrambling to implement some of these new requirements, and I hope that many of them will consider the reality that right now they have opportunities to simplify access to other existing forms of Medicaid and Medicare savings program coverage. And I hope they will use this moment in time to take advantage of those opportunities, even while they have to take on new challenges. Longer term, we won't just think about how we can mitigate new harms, but we'll think about how we can solve some of the long-term access problems that have vexed us for a really long time. As we mentioned, I'm leading a new endeavor where we'll draft some state and federal model policies that will attempt to address some of these issues. I hope in some small way we can contribute in a meaningful way, but regardless, I hope I'm not naive to think that these should be bipartisan issues, right? There are people in this room who have different perspectives on the appropriate size and scope of America's safety net. But I hope that there's something close to consensus that we should make it simple for people to access the services to which they're entitled. We should make it easier for the government to successfully administer the benefits that they're in charge of overseeing. So, and if we want to expand those programs, we should do so in the most efficient way possible. And if we want to shrink those programs, we should do it in a way that doesn't involve making everyone go through enormous administrative ideals.
Great, thanks, Tim. Alison, I'm going to go to you next. You worked on long-term care policy both from inside and outside the federal government. including through periods of deep political division. So in this moment of divided government and possibly for the foreseeable next few years of divided government, what kinds of long-term care policy changes are actually feasible, and where do you see real room for progress, even amid this constraint?
So I got asked the question that was like, how to be positive, which, is not my usual place I start from. And I'll just say two things before I answer this. One, I've been involved both personally and professionally in developing LTSS before there was such a thing as home and community-based services, before we had very clear civil rights laws that created, living and participating in your community as a civil right. And I try to keep my eye in the long game when I get down and think about the huge progress we've made. Sometimes it looks like this. And also in this moment, thinking about how do we measure progress. For anyone who knows Wade Henderson, who was a great civil rights leader, there are times we can measure progress by big milestones. Times where it is like the fight inch to inch to inch, and sometimes the win is holding our ground. I think Narda's asking me to find the inch by inch. I really think we're in the, unfortunately, hold our ground moment. But I actually do think there are some small things where I am seeing opportunities. And so to be positive, I'll put a few out there. There is so much momentum in thinking about long-term services and supports and home and community-based services through a care lens and in a bipartisan way through a supporting family caregivers. And we've really seen momentum in a bipartisan way at the state and national levels. We just saw in the bill that just passed in February, the budget bill, an expansion of eligibility for the lifespan respite program, and we saw increased funding to that program, as well as the Family Caregiver Support Program in the Older Americans Act, which actually covers caregivers of people with disabilities too. This Congress, there's more than 20 bills focused on caregiving, many of which are bipartisan. They are not the big milestones, but okay, we're in the inch-by-inch world. And at the state level, I live in Virginia, and just looking this week, for the first time, we may have a paid family leave program. So and we're seeing that in other places. So there's some inch-by-inch there. In the aging world, there has been a lot of momentum around multi-sector plans on aging, which is a way really to think about community living, long-term services and supports, and affordable, accessible housing and healthcare. And I think those tables are going to be a place to find the inches, maybe to stop the rollback. And more, we are seeing people aging with and into disability being part of those conversations and the cross of aging and disability. One big issue around Medicaid HCBS is the fact that people cannot move state to state. People are really stuck. And from a principle level, maybe not from a huge thing, but in the inch by inch, also in the end of the year bill was this new authority for military families receiving home and community-based services. And it is our first toe in portability of Medicaid, not even starting till 2030. We'll see if it's even able to be operationalized. But I think a big policy toe in the water that's good. And then the last thing I'll say is virtually everything about HR 1 is about huge cuts to Medicaid and the ways that we will all have to take the national fight to a 50-state fight to prevent cuts. But there are two things in that bill that I think maybe in the long run will be helpful. One is a new 1915C authority that doesn't require an institutional level of care. Doubt we're going to get a bunch of uptake right now, but it is something that creates an opportunity. And then finally, in the Rural Health Transformation Fund, we did see a few states focusing on, among many other things, stabilizing direct care workforce. So I think there are a few things, but the reality is most of what we are doing is holding the ground on Medicaid LTSS because that is the big game in town. But there are places that we can continue to move things forward in the short term while we are also really visioning. I mean, the one silver lining, as Tim said in some ways, of a decimation of what has been is we are not in a rebuild and just go back to what we had that didn't really work mode. We are really thinking about, and I know you'll be asking about this, how do we really think about a long-term care system that works for everyone who needs LTSS?
Thanks, Allison. And I do want to acknowledge and, reinforce, obviously the holding the ground piece is really critically important. And we know that you and many others in this room are working on that. And also just to reinforce, what you were saying about the multi-sector plans on aging. The SCAN Foundation has been working on these both in the state of California as well as in states across the country for some time now. And there are others, Kevin Prindiville, I think, is here somewhere who can probably speak to this better than I can. But in terms of that holding the ground element, year after year, in recent years, there have been proposed cuts in the budget to aging services programs. And it has been the hard work of the advocacy community and those behind the multi-sector plans on aging that have been able to put the public pressure on reversing a lot of those cuts. So I can't understate how important those efforts are, and the fact that that coalition is both working on offense and defense at the same time. Nicole, I'm going to go to you next. You've been at the forefront of efforts to reframe long-term care, not just as a personal or a family burden, but a real gap in our social insurance architecture. So can you start off by speaking to why long-term care continues to be one of the most glaring omissions in that framework, and where you see momentum now, both in policy and the broader movement for care?
Yeah, thanks for the question. I do want to say that I do think obviously that we have seen a lot of shifts even within the fight around Medicaid. The growth and understanding I think is going our way in terms of momentum, but really so much of the problem is that the systems are still misunderstood. So many people think that Medicare is going to cover long-term care needs, long-term supports and services. And we have data and polling from Caring Across Generations. Apologies, anyone who's been in a meeting with me, because I say this all the time, but I think it's really important, which showed that 93% of Americans across the political spectrum believe that Medicare should cover long-term care. And the more troubling component was that 67% were very, very strong in their belief that it already does. And that just shows the massive lack of understanding. And so much of why we're in the point that we are is people think Medicare will cover it. People will think that private insurance or employer-funded insurance is going to pay for long-term supports and services. And it's not until people are in a crisis point when they find out that that's not the case. And even in the instance of Medicaid, which is obviously, as everyone in this room knows, is the main funder for long-term supports and services in this country, because of the fact that it's a state and federal partnership, there's a lack of understanding from people who are even receiving the services of what's paying for it, what system is paying for it. So I think all of those sort of education gaps and just complexities makes it a harder piece. It's also massively expensive. I work at Caring Across Generations. We really focus on the whole of care. So we focus on aging and disability care, access to home and community-based services, but we also think about childcare and paid leave, because we know that we have to solve for the whole of the care infrastructure, the care economy. But the reality is that we've seen some advances in understanding of the cost of childcare and that sort of thing. But when you think about the cost of long-term care, it morphs the cost of childcare. Not to say we shouldn't address them all, we should. But part of it is that massive cost is falling on families. They're in a crisis point. And so when it comes to activating them, they tend to be busy and also, frankly, like a little bit feeling that the system is rigged against them. And so when we have from data that shows from our partners at the National Partnership for Women and Families that unpaid care costs the economy the work of unpaid caregivers gives the economy $1.1 trillion a year. That's what's filling in the gaps. And the cuts from this past summer are, a death by 930 million cuts. And we're going to be seeing that. And we have to be able to also make the economic case, which is, I think, also what we've struggled with in long-term care, but we're getting there.
Wonderful. Thank you. I get the sense that the folks that have gathered here today are folks that are really eager to find ways in this moment to be able to act, right? And I think that that's hopefully a theme that's coming across in this panel of whether it's holding the line or whether it's moving incremental policies forward or working towards a bold vision, that, you know, people want to be able to contribute in meaningful ways. Across all of the work that we've been talking about, a theme has been that readiness, being prepared with the ideas, the coalitions, and the strategy. So what does being ready look like in the work that you do? I'll start for Nicole. Do you want to go first?
Yeah, sure. I think that readiness includes both the coalition side and the policy side. When we had a massive moment where the holistic view of care could be addressed, we didn't have the policies that we actually wanted to see become law. So we are already, there's a lot of quiet conversations happening where we're going to be able to have that answer. So that's a really important component of readiness. But you also have to have the people behind the issues. So many people, we ask them to share their stories, but that story needs to be shared with an expectation of a solution and an expectation that the system can catch them. And I think that that's also what we as advocacy organizations, but everyone really needs to be thinking about, is how do we make sure that people feel part and ready when that moment comes to be the movement that gets us there.
I'm gonna ask one follow, and this can go to anyone, but I think one area in particular is this sort of the conversation around the coalitions of aging, disability, and labor in particular, and a recognition that that partnership has come a long way. But from your vantage point, is it poised for that moment? And if not, what is it going to take to get there?
Yeah, absolutely. I like to say that the tension between aging, disability, and labor is where I've built my career. And I say that with lots of friends from all of those communities sitting in the audience and across the DMV. But the reality is that it has come a long way. And so much of what happened in the past was because different considerations weren't thought of, different constituencies weren't at the same table, and that just isn't the case anymore. And I think that what we've seen in 2017 with the defense work, what we saw last year with the defense work, is that's when it's a kind of easier for folks to kind of put down their respective viewpoints. But I'm also really excited to say that when we are also forward-looking, that same mentality is there. And so the Disability and Aging Collaborative really should be the Disability, Aging, and Labor Collaborative, because we do have active participants from all of those industries, fields, and it's so important that we're thinking about that way, because if we don't solve for all, including the direct care workforce, aging populations, and disabled people of all ages, then we're not actually solving for all.
And if I could just add to that, I mean, I love being on panels with longtime friends where it's like +1. And also, like Nicole, I have also lived at that intersection of aging and disability, also with labor, but, most recently leading the administration for community living, which was like in the most direct way almost 15 years ago, bringing together aging and disability around literally this issue, the issue that older adults and people with disabilities want to be part of their communities. And I think we are finally starting to see some of the silos in long-term care policies being reflected, that people are at the same table. For most of my career, there's been an aging table that comes from a lens that I don't even think accurately reflects all older adults, but comes from a long-term care lens of someone will start needing some support, it slowly comes on, it's a small amount, and then, when you need a lot, you go into a nursing home. That had kind of been the model. Not thinking about people who might have lifelong disabilities or more significant needs. And I think I'm part of an effort that SCAN is helping support around looking at what the legislative proposals have been over time. First, long-term care financing, now we're looking at caregiving, and you see the trajectory has gone from very siloed aging proposals that come through that lens and very separate visions on kind of disability proposals to now, I think being ready for me means we are all at the table. We are not recreating siloed systems. We think about functional needs, not what is your age, what is your disability label, which is so what our systems are built on. And I think when you have an everyone proposal and mindset, it helps build the coalitions, it helps build the momentum. And I just think the visibility, frankly, that came out of COVID, really seeing what happens when people lose care, combined with 11,000 people turning 65 every single day, disabled people living longer now, many with aging parents who we're now in a how do we put in place a system, has just created the politically impossible is going to become the politically inevitable, I think, because of those demographics. And we need to do it together. And really, that is the part of being ready.
We have some structural issues that still, like, my panelists have to fight here, which is the reality that in long-term care world, we still, frankly, even more so now, operate in a world where there are so many authorities that themselves are separated by population group that I think we have a structural problem that you guys have done amazing work to kind of fight against. But my readiness answer would be informed by experience in various executive branch agencies. And it's wrestling sufficiently with the technical and operational details of any of our policy objectives. I am embarrassed to say how many times that I was on the receiving end of a good idea that we just couldn't, like, there was no debate, like, this is a good idea, we should fix this problem. But it still takes you 2 years to solve it, not because of bureaucratic incompetence or laziness, but because we traffic now in a system that is so remarkably complex that even the simplest things have unintended consequences and ripple effects that can take a really long time to unwind. There aren't a lot of us here who think that we shouldn't fix issues related to Medicare Advantage risk adjustment, just like there aren't a lot of people at CMS who don't think we should fix issues related to Medicare Advantage risk adjustment. The problem is every solution has a million complicated challenges to resolve, and they're not all political ones, some of them are technical ones. So I think in our orbit of trying to simplify enrollment into public programs, or trying to make HCBS transferable so you don't have to get on a new waiting list if you move from one state to another state. Those have really tough things that you have to grapple with, and it's easy to say we should fix that. It's hard to put in the time and effort and technical work to figure out the best way to fix that. But I think we have to push ourselves now to be ready when those issues have a moment. When the window opens. And that's just hard. That requires discipline and technical work and energy.
So with that in mind, obviously we've talked about being able to advance policy forward, both, again, the incremental and the bold vision. Tim, you also brought up a really good point right now, just how complex the system is. And so how do you balance, moving within the system that we currently have, and defending those efforts and trying to make them a little better versus, for lack of a better term, working towards sort of blowing it up and starting over and building something that does reflect the realities of today.
All right, I'm going first this time. I couldn't even let you finish your question. I was afraid I was going to get yelled out. I think we have learned over the last multiple rounds of major health legislation, and we learned, if we listened to the prior panel about trust issues, that we are in a dangerous place if we invent important new policy constructs that take us years and years to deliver on. And I don't think that means we should be unambitious in fixing things. It just reinforces that where we see opportunities for forward progress, however we define that, we need to make sure that there are concrete and tangible outcomes from that in the short term, even while there are longer term bigger objectives that will take a much longer period of time. And again, incrementalism is not mutually exclusive with ambition. But I just think we have to remember that whatever our vision is, needs to have concrete results that we can show. We are operating in a world in which even things that were just not politicized half a generation ago are now whipsawed back and forth every 4 years when there's a change of administration. And that's a really tough way to run the nation's big healthcare programs. But it also means like you've got to do things that have tangible impact in a relatively short term.
Yeah, I think that's exactly right. And I think that there are going to be moments to show that even in the midst of the cuts. Obviously, we see states already doing very terrifying things, but we also just saw this past week Governor Whitmer from Michigan taxing gambling and nicotine products to raise $800 million to avoid Medicaid cuts. So I think we're going to have to lift up those pieces at the federal level too. I think even in the kind of incremental thinking, 2027 is the next reauthorization of a 20+ year pilot project, the Money Follows the Person program. That is a very important program that has moved a lot of people who choose to out of institutional care into their homes and communities with some flexibilities. And I think that's a great opportunity for states to show how with some of those flexibilities, a lot more people can be served where they want to be served. And also there are bills that we and Alison and I in particular, along with some other colleagues, spent a lot of time in the COVID era and before, called the HCBS Access Act that we know is going to be introduced in both the House and the Senate coming up here, which would do a lot to address the portability issues, that would do a lot to address the variances in access to home and community-based services depending on what state you live in. And there's also a lot of conversation in my personal capacity. I was honored to work with the Harris campaign on their Medicare at Home proposal. And I think all of those pieces, you can get to the bits and pieces, save what you can here and there in the current system while also thinking about the systems that we need to create in an inclusive way. And I think that there are a lot of those pieces already out there so that we don't have to reinvent pieces of it.
And if I could just add to like your specific question of like the short term and long term, we have no choice but to fight to prevent cuts because people are really on services now. We know what it's going to mean to people. I have gone from being, I'm an advocate on the outside. When I'm in government, I'm an advocrat, and now I'm an advodemic. And, we are looking at very predictably what will happen if you, decrease by 10%, HCBS in X state. How many additional nursing home admissions will that be? How many family caregivers are going to have to leave work? How many people are going to go from individualized supports to congregate supports? How many people will die? And thanks to some funding from the SCAN Foundation, like the narrative right now is this is not going to impact older adults and people with disabilities. That is not true. That it is already happening, and as part of this initiative, we are tracking what is happening in states and tracking impacts because we need to, help advocates be armed to stop and at least moderate changes as much as they can. We have to document what they are and what it means, and that helps us with the long view. I don't think anyone is like, let's just go back to where we are this moment. Even if there are cuts, the goal is not just to undo cuts. It is to really show what happens when you cut services, what happens to emergency room admissions, what happens to nursing home admissions, those kinds of things that build momentum for the long view. So we have to, what's the saying, walk and chew gum, because this is real people's lives happening right now, and it is not the political moment for those blue sky changes that we are talking about. But when that window opens, we have to be ready, and really we must do both.
I'm sure that there are probably people in the audience who have questions for these amazing folks. So if you do, please raise your hand so we can make sure to get a microphone over to you. And I'll ask one question while we're waiting for folks to raise their hands. But, obviously you all have mentioned stories that have shaped either how you see these issues, or how stories have been able to help change the hearts and minds, of others in the policy community. And what is different now in this moment about lived experience, and how do you see that in your work? How do you see it resonating, and how do we continue to keep that as a core focus, even as we're wrestling with things that are really technical maybe, and might not necessarily sound very sexy, but have really strong implications for people?
Yeah, well, I think that stories and just in general, something that Carrying Across focuses on is narrative change and the messaging that we need to go alongside the policy shifts to break through the public education and other barriers. And a great way to do that is stories. But we have to utilize, and I mentioned this earlier, but making sure that people are sharing stories with an expectation for change, and also utilizing storytelling to be a tool, because frankly, obviously there's a lot of mistrust in government right now. There's a lot of mistrust in government programs, and a lot of the things that we're talking about, whether at the state level and the federal level, is about approving and expanding these programs. And so using stories to make it that individual case, because also sometimes when we're talking about trillions of dollars or billions of dollars, frankly, it can go over people's heads. But if you're talking about one family's conversation around a kitchen table to put together what in my family we call the care conga line for my grandparents in their 90s of who's going to step in because there isn't a system of support, when you get to that individual case, it's easier to have policymakers understand the impact, and also it's easier to get people to see that, wait, this isn't something I should be handling on my own. This isn't a personal failure, and to get them into the movement for that broader push.
I think collectively, we're doing, if we had this event 20 years ago, right? I think we're doing a better job now, like caring about, thinking about, and meaningfully incorporated lived experiences into our work. In 20 years into the future, I hope we'll look back and say we were so short-sighted, and so right. And so platforms like yours, the people say is like an input, and we heard stories like on that last panel that I think all these things like teach us really important things. One, but to pivot for your question, when we actually talk to people, I think one of the takeaways for me is often it's like people's experiences are not in the boxes we focus on, right? Like it's not like give me your experiences and then they just give you long-term care, right? Like their experiences, they go so much further beyond. So I think we've made a lot of progress where I'm not sure we made any progress as I see Bill Hoagland in the audience. I think I want to pivot this back to like budget stuff, right? Like when and the investment comments from the earlier panel, right? Like I don't think we've made enough progress on realizing the interrelationships between long-term care inadequacies and what that means for the workforce and right, people's ability to go have a job that that they want to have and pursue their own career in the same ways that we made more progress here, but we've struggled to tie all of the budgetary dots together between adequate mental health treatment and our incarceration system and all these. We've made maybe a little progress, but just not enough. And I do think the lived experience intake is also the reminder that oh wait, these things all affect each other in ways that are not, they don't tie into the boxes that are easy for us to process as bureaucrats or academics or anything else. I do think that's a hole we need to try to fill.
I'll just add, and then I know we had a question over there. I think two things that I feel like, having done this work a very long time, have changed a lot in really kind of the post-COVID time. I mean, one, it was probably the pivot to talking about this as care that made people just see it in a universal kind of way. I think when we move from using technical terms and we start talking about disability care, aging, whatever words people use, members of Congress really got it. They were like, oh yeah, I have an aging parent, or I have this family. It's something everyone experiences. And I think the stories are what did that. You hear what it is. People don't see themselves as giving care, but when you talk about what it is, they're like, oh yeah, that's me and the sandwich generation and all the things. I think, yes, and to what Tim just said, I think we've actually gotten better about talking more about a LTSS ecosystem and talking about not just it's about financing formal services, but talking a lot about, even if we have all these formal services, if we don't have a workforce who can provide those services. And actually, I've been surprised, BPC, even when they put out a thing on workforce, recognize this brings in issues around, not just living wages, but immigration issues. It is complicated. And when we started tying in family caregivers, who literally their story is, and I think COVID showed it very starkly, hey, when you lose formal services, whether you want to or not, you have to take over that care. You end up leaving the workplace. And so I do think we are starting to have this broader narrative around the pieces, but we need to do more for sure. And I know Carrying Across is doing an excellent job lifting up all of those pieces.
Thanks. Just to jump on that point, not to jump ahead of a question, but I think that, because to your point on care, we both lived through that transition, and I just want to say this in this room in particular because academics have such an important role, the research has such an important role, but if we didn't spend a long time, decades maybe, talking about like, should it be long-term supports and services or services and supports, or we can't say care because it might offend this part of the, instead of getting people to understand the importance of words being relatable, I just want to say we're not going to win. And so I just, thank you. That's my soapbox that I will continue to stand on because, and I say that as someone who didn't identify as a caregiver, despite having a brother with autism that I do a lot of direct care for, and grandparents in their 90s until I started working at a caregiving organization. And that's a really important thing because we need people to identify, and we're not going to get people to identify if we use wonky words.
There was a question.
Thank you so much, Caitlin Connolly. And Alison, Nicole, we've worked together for a long time in those coalition spaces, right? So we really saw the power of all the stakeholders coming together, advocating for our shared vision, as well as just the interconnectedness of the care economy. And so on that note, I know you started to touch upon this, but if we imagine a future where we have a care economy that's truly able to support people's needs, the workforce that we need to be preparing now to be ready for that future, and a workforce that, quite frankly, AI can't do, and like the critical work that is, and how do we make sure that this fundamental foundational workforce is the economic boom and recognizing the value, the true value of those workers. So just open it up to thoughts.
Yeah, I mean, that has been one of the huge issues around particularly home and community-based services is the fact that we have the direct care workforce that is so underpaid, that there are not opportunities for advancement, and that are incredibly, I would almost use the word disrespected in terms of the jobs. And there have been lots of different strategies tried. I mean, one of the good things about in COVID, where there was increased funding for home and community-based services, like many states tried, okay, how do we increase wages? How do we try different recruitment strategies? But it was one-time funding, and they did it in very, very cautious kinds of ways that are really problematic. When I was at the Administration for Community Living, we knew we had to try like every lever we had and brought together ACL and CMS and really needed to get the Department of Labor engaged in, frankly, they had a campaign around good jobs. None of these jobs met those qualities, so they were like, we're not gonna recruit people into this. And we were like, how about the solution is we work to make these jobs better? We have not found a silver bullet. We have both. This is the #1 most growing occupation. Of course, that's because we have a huge aging population. And if you look at the data, we have providers who are closing down services and declining referrals, majority of them, because of workforce challenges. And I guess what I'm most concerned about, having just started this tracking work, and it is barely starting, states are gonna be like, we're not gonna cut services, we're just gonna cut provider rates. That's already out the gate. We are seeing that in many states. Well, guess what? If you cut provider rates, you're cutting actually wages to workers, and it's the same as cutting services. People are gonna get access on paper and not be able to find anyone to provide. So we have got to be talking about this, and really fighting together and saying, this is not a cut. This is a cut just like everything else. And then also be looking at how we can think about apprenticeships, working with community college. I mean, there are some great things from the labor world that TOE's started to go into that we need to move forward on.
Yeah, and I mean, I think that what we have to make sure that we're doing is that when we're talking about expansion of access, when we get to that moment, whether it's in Medicaid, Medicare, that the workforce is central to it, because the direct care workforce is the human infrastructure that I always say that the what we can do for family caregivers is make sure that there's a system enough that care is actually a choice instead of the only option. And that's only going to be possible with a well-paid direct care workforce. Obviously, there is historical racism, gender discrimination, because the vast majority of direct care workers are women and women of color. There's obviously also immigration components into that all should be addressed and need to be addressed. And because we have to make sure that as we're growing access to these services, we're not growing access to bad jobs. There's no such thing as a worker shortage. There's a shortage of good direct care jobs that pay family sustaining wages, that have benefits. And I know that I will feel much better when my brother or any of my grandparents are getting support from somebody who can support their own family. And that's why we have to think of the holistic view at Care Can't Wait. We think about the foundation of childcare, paid leave, and aging and disability as a strong direct care workforce. And so it has to be central to the solutions. As an example, the HCBS Access Act that will be reintroduced pulls components of the Better Care, Better Jobs Act that address the workforce into the access bill, so that you, again, at the center are addressing that. It also has some nods at the family caregiver component. So it's important that anything we're putting out there is inclusive of that from the very beginning.
Other questions from the audience? I will take my moderator right to ask another one then. Nicole, you brought up, and I think we heard reinforcement and clapping and applause about the point that you made around the messaging piece of this, which I think can't be understated. As someone who has worked on the Hill and tried to sort of sell these policies to other congressional member offices and, to some extent to the public and to advocacy communities, HCBS, HCB what, was sort of often what we were told. And we were also often told, oh no, my state totally has that, or our district totally has that. But when people would go a little bit deeper, you'd see either what they're calling HCBS is a really bare bones, barely even an hour or two of personal care attendant benefit, and in name only. But even broader than that, you want people to feel like this is something that they can champion, that it's something that is a winning issue to move forward. And so, Nicole and others, just curious in the work that you're doing, how you are thinking about that messaging component early on, right? So that it's not an afterthought once the technical policy is developed and the advocacy community is behind it, but that from the beginning, folks are talking about it, and it's probably not folks in this room, right?
Right. I think that last point is the first point I would make, which is that we have to rely on narrative and messaging strategists to talk about this issue, because I think, frankly, that's what we haven't done, which is why I love HCBS. And I know obviously I can talk about it in my sleep, but most people can't, even people who are receiving the service. And so you have to be able to have folks that have the rooting in how you actually talk about an issue to the vast majority of people. Something that we're thinking really a lot about at Caring Across Generations is audience first strategies, because we actually know the polling shows bipartisan support across the political spectrum of these issues when you don't say, do you support access to Medicaid HCBS? Because people don't understand Medicaid and people don't understand HCBS. But when you say, do you support government funding to support aging community members and disabled communities members to live in their homes and communities, it goes astronomically higher. So why aren't we using the same language that we use in polls in the general public as a really simple example? But also there's different people that go to specific type of media. How are we directing messages that go to what we call, or what, it's not my framing, but tough cookies that are not people who would think about this issue but are actually deeply in it but don't realize it? That's what we have to do, and that's what we have to rely on communications and narrative experts to actually get us there.
Can we pull in Medicare a little bit too? Because I think there's another place where we've operated in totally different spheres. It's been 20, almost 30 years now of like community integration and Olmsted kind of language informing what we've been doing on the Medicaid side, and we have incorporated almost none of that into the Medicare program, where we still have really restrictive requirements about using a wheelchair, and it has to be primarily for use in the home, not like we have what I think. We have they're such anachronistic concepts that we've still allowed to continue in the Medicare program in ways that I think have profound implications for older adults and people with disabilities. And I think we also need to find some ways to bring in the community integration independence concepts into the other healthcare program too.
Yeah, definitely. And to your point, I think when you think about things like the home health benefit and Medicare, Alison and I are usually share a brain.
Setting up.
And you see the doctors not taking it up. I just went through this experience with my grandma Lou, and homebound has a meaning, but if doctors understand it in a different way, then you're going to see it sounds simple, but it's actually not. And so in order for to get to both Medicare and Medicaid and just the issue in general, you have to speak in terms that everyone from providers to family members understand.
So we're short on time, so I want to ask our panelists if there's just something that you haven't been able to share already with this group that you think is important going forward. I think we heard a lot today about the importance of, moving, even in this, current environment of volatility, both holding the line, protecting what's already there, being able to make the system work better for people, both in terms of the short-term incremental changes that have real impacts on people, but also being able to have some of that aspirational vision, which gives me hope as I continue to do work in this space. And I think also we talked about real concrete ways that folks in this room can get involved in a lot of those efforts. And I'm just, again, really appreciative of all the work that you three are doing in this vein, but anything that you'd like to sort of share with the audience as we close up?
I guess I will close out by saying there's something for everyone to be doing in this moment, whether you are probably not in this room, the person who can help on messaging and who are the right people to be telling the stories. If you are an academic and a data person who is really tracking what is happening, if you are a technocrat, and I've had many times in government too. Yeah, I can write a reg like nobody's business. We need y'all too. And there is something for everyone here. Everyone doesn't need to be part of everything. If you're part of the Blue Sky Dreamers, if you're part of the Inch by Inch, if you are part of the get people to advocate and make the case on a cut to HCBS is a penny wise and a pound foolish. There is something for everyone here. And this is a moment of major transition in this space, and we all need to be part of it. If you believe in social insurance, in any way, shape, or form, this is your fight.
And can I just reinforce, the Blue Sky people and the Inch by Inch people also really need each other. We do. So I really think that collaboration is key. But
yeah, to that point, nothing should be seen in competition, and everything should be seen as rising tides lift all boats, and that's going to be a really important piece moving forward. The only other thing I would add, I talked, we've said care economy, we've talked about it, but the more that we can see and show the economic impact of not addressing these issues for older adults, for family caregivers, and for disabled people, the better our opportunity is going to be. We didn't have those arguments in a really effective way around long-term care in the Build Back Better fight. We need them now. We have some of it. It has to be down to the individual level, like I talked about, all the way up to the systemic level. Businesses have to be getting engaged. I think more and more people are, because sandwich generation caregivers are in the workforce in such a major way. And so anything that can be done to support that will make the case as we're building the policies out.
I agree with all of it. I had the great pleasure to be in some legislative hearings in Richmond, Virginia recently, and it was just like this wonderful reminder that state government has a really important role to play too, and state government tends to operate in a completely different cadence, in a completely different ways than we're used to in the congressional level. And while not always, often in a much more functional manner. And so for all of us who care, especially about Medicaid, but all other programs too, we need to remember that there is so much important work to be done at the state level as well.
Great. I promised you guys we wouldn't be late for lunch. So
Narda runs a tight ship, and don't forget it. Thank you to this amazing panel.